Webinar of Digital Education Committee on very important topic, that is endocrinopathies at menopause. And it's a proud privilege for me to welcome you all on the behalf of Digital Education Committee. Our committee has been launched in year 2020 under the presidency of Neelam Agrawal ma'am. And the goal of Digital Education Committee is to provide flexibility in learning, allow access to the educational resources anytime, anywhere, and personalize learning experience along with the reducing the cost and expenditure of society and its member. Our aim is to provide high quality education to all and elevating the members to the global and updated knowledge of midlife and menopause and making digital infrastructure as a utility to all. So keeping this motto in mind and our heart, I want to welcome our chief guest and speaker for today's webinar, Dr. Pushpa Shetty ma'am. She is the president of IMS. Just a minute, I am getting a call from Pushpa ma'am. Hello. Yes, ma'am. We will wait.
When we talk of fat, it is only talked of that we have put on weight, we have fat all around. But what is this fat doing? How is it acting on our bodies? That we have never really thought of. So when you talk of fat as an endocrine organ, this is what all it affects in your body. It affects your vascular tone control, your coagulation, your immunity, your appetite regulation, glucose and lipid metabolism, reproduction, angiogenesis, fibrinolysis, body weight homeostasis, and so many others. So to introduce the topic, adipose tissue is a complex, essential, and highly active metabolic endocrine organ. Besides adipocytes, adipose tissue contains connective nerve matrix, nerve tissue, stromovascular cells, and immune cells. Together, these components function as an integrated unit. Adipose tissue responds to afferent signals from hormone systems, the central nervous system, and also expresses and secretes factors with important endocrine functions. Adipose tissue is a major site for metabolism of steroids and glucocorticoids. There is adverse metabolic consequences of both adipose tissue excess and deficiency. So friends, remember that it is not only the excess of adipose tissue which is bad, there is also the deficiency which is bad. A better understanding of the endocrine function of adipose tissue will lead to more rational therapy for those increasing prevalent metabolic disorders which are so rampant in our society now. So this is the adipose tissue, and see how it acts like an endocrine organ and an autocrine and paracrine organ. On the endocrine side, it is secreting leptin, TNF-alpha, IL-6, sex steroids and glucocorticoids, angiotensin, PAI-1, adiponectin Q, and on the autocrine and paracrine side, it is secreting PAI-1, TGF-beta, TF, adipsin and ASP, TNF-alpha, IL-6 and leptin, renin-angiotensin system, steroid hormones. So it is secreting not only endocrine hormones, but also paracrine and autocrine hormones. So that the adipose tissue, is made up of adipocytes, and the adipocytes are 4 types that we know of now. They are white, brown, beige, and pink. So they are named according to the color. Classified, not that they are that color, but this is the color that is given to them. Classical classification is white adipose tissue and brown adipose tissue. So the white adipose tissue, or VAT, it is critical for energy storage. It has endocrine communication. It does endocrine communication, insulin sensitivity, comprises the largest adipose tissue volume in the humans. So the largest volume of the adipose tissue present in the humans is made up of the white adipose tissue. Then coming to the brown adipose tissue, or BAT, actively contributes to whole body fat oxidation and diet-induced thermogenesis. BAT is present mostly in large numbers in the newborn babies because it regulates thermogenesis. Now, some of the factors secreted by the white adipose tissue. These are free fatty acids, leptin, IL-6, TNF-alpha, sex steroids, adiponectin, glucocorticoids, bispatin, resistin, PAI-1, angiotensin, and others. This is secreted by the white adipose tissue cells. Now, the brown adipose tissue cell, this is the brown adipose tissue cell, and with all the factors that it is secreting, it affects the bones, white adipose tissue, brain, liver, pancreas, and the heart. Then these are the 4 types of adipose tissue cells described separately. The white adipose tissue cell has a large lipid droplet in the center, single large droplet, the nucleus and the mitochondria. The brown adipose tissue has very small droplets of lipid and nucleus and the mitochondria. The beige adipose tissue has small and slightly bigger adipose tissue, the lipid cells also, and that is what gives it the beige hue. And the pink adipose tissue has milk droplets in the cell. So the recently 2 additional adipocyte hues have been added, that is the beige and the pink. They have been described. Beige adipocytes display characteristics of both brown and white fat cells. They arise in response to cold exposure. However, many studies have identified that diet, exercise, pre and postbiotics, pharmaceutical agents, plant-based bioactives, and adipokines can also induce beiging or browning of the white adipose tissue, which may protect against obesity and metabolic dysfunction. Now coming to the pink adipocytes. Pink adipocytes were described as early as 2014, arising in the subcutaneous white adipose tissue of female mice during pregnancy, and they persist throughout the lactation. But it is uncertain whether these pink adipocytes form in the humans also or not. The white adipose tissue makes up the largest adipose tissue volume in the human body and undergoes the most expansion during the obesity. So this is the adipose tissue that expands during the obesity. So it plays an important role in normal physiology and the metabolic dysfunction. Now, the adipose tissue and the lipid metabolism. Adipocytes store triacyl glycerols or TAG under conditions of energy surplus. This we all know. When there is energy surplus, it is stored as the lipids and release fatty acids to supply to other tissues during fasting or high energy demand. Adipose tissue is central to the regulation of systemic lipid metabolism. A critical balance between lipogenesis and lipolysis within adipocytes is established to maintain whole body insulin sensitivity and energy homeostasis. Now, this is a very important diagram which shows you both lipogenesis and lipolysis. This is lipogenesis happening here, and this is lipolysis. And a balance between the two is maintained to liberate glycerol and free fatty acids into the peripheral tissues. Now, the pro-lipogenic states are when there is a lot to eat or when there is insulin. And anti-lipogenic state is when you're fasting or under the effect of growth hormone. And pro-lipolytic stage is when you're fasting, exercising, cold exposure, exposure to catecholamines, growth hormone, glucocorticoids, tumor necrosis factor. And anti-lipolytic is when there is a lot to eat and when there is insulin. Now, the endocrine properties of the adipose tissue, the most important part, the theme of the talk. Adipocytes and other adipose tissue cells secrete a variety of mediators, including exosomes, microRNAs, lipids, inflammatory cytokines, and peptide hormones that act in both paracrine and endocrine modes. Substantial progress has been made studying these 3 endocrine hormones that are almost exclusively produced in the adipocyte tissue. These are leptin, adiponectin, and resistin, and their expression in obesity, their receptors, and effects on the target tissues, including metabolic actions, have been studied in detail. The dysregulation of any one of these hormones can lead to systemic metabolic dysfunction and to the pathogenesis of chronic metabolic diseases and some types of cancers also. So this is the fat cell, and here it is secreting mainly adiponectin, resistin, and leptin. And these are the other endocrine hormones that we have talked about that they secrete, but main are adiponectin, leptin, and resistin. So coming to leptin, the most important one. Earliest endocrine hormone of adipocyte origin to be discovered was leptin. That was in 1949. The first observed function of leptin was its effect on food intake. Leptin levels in mice and men strongly correlate with fat mass and play a key role in body weight homeostasis. Increased central leptin signaling inhibits food intake and increases energy expenditure. Leptin deficiency, such as during fasting or starvation, has the opposite effect. Leptin levels strongly correlate with fat mass. Leptin acts as a sensor of energy stores, signaling the availability of body fat to the brain and regulating adipose reserves. During obesity, the negative feedback loop between increasing leptin levels that signal high energy availability and inhibit food intake becomes disrupted at times due to the development of leptin resistance. This is in line with something like what happens in the insulin resistance. The inability to respond to leptin despite having sufficient levels in circulation during accumulation of excess adipose stores is what is leptin resistance. Leptin resistance that accompanies obesity appears to result from selective impairment of leptin's ability to reduce food intake while preserving its other capacities to raise energy expenditure. Leptin also has central nervous system effects, including modulation of reproduction and thermoregulation. Research into the role of leptin to mediate anxiety and depression is currently ongoing. Leptin can also act peripherally on hepatocytes and pancreatic beta cells to regulate glucose and lipid metabolism independently of its central nervous system action. Risk for many cancers is high in patients with obesity. We all know that, in whom leptin levels are also high. Leptin has been implicated in tumorigenesis also because of this fact. Leptin levels or leptin signaling has been found to be dysregulated in breast, thyroid, endometrial, and gastrointestinal malignancies. Postmenopausal women with obesity have a 20 to 40% greater risk of developing breast cancer compared to normal weight women. So naturally, in these patients, the leptin levels would also be very high. So here you have leptin, which has both a central nervous system action and action through the adipocytes, and it acts by improving the central control, energy homeostasis, improved adipose tissue function, better adaptability to environmental conditions. Now coming to the adiponectin. Adiponectin is a unique and extensively studied adipocyte-derived hormone with complex biology. Unlike leptin, adiponectin levels decrease as a result of increasing fat mass and obesity. So as obesity increases, adiponectin levels decrease. Adiponectin is a protective cytokine. Now you have to remember, this is the only protective cytokines liberated by most of these adipocytes. It is anti-hyperglycemic, anti-atherogenic, and anti-inflammatory. Adiponectin enhances fatty acid oxidation. Adiponectin can activate AMPK and can modulate lipid metabolism by increasing mitochondrial density and mitochondrial DNA content. Adiponectin has diverse effects in many tissues, for example, bone and cartilage, and can act in an autocrine or paracrine manner in the adipose tissues and other tissues. Adiponectin reduces plasma glucose levels by inhibition of hepatic glucose production. It promotes hepatocyte survival, inhibits hepatic fibrosis and inflammation, stimulates fatty acid oxidation, and modulates fatty acid uptake and metabolism. Adiponectin has beneficial effects on the liver, where it protects against metabolic dysfunction and hepatic disease. Finally, adiponectin is also cardioprotective. I'm not able to move my slide. Right. So here you can see this is when the visceral fat increases, adipocytes undergo hypertrophy. What happens? All the the inflammatory cytokines increase. It is only adiponectin which is decreased. So visceral obesity, decreases the only protective cytokine, that is adiponectin, whereas it increases all the inflammatory cytokines. Now coming to resistin. Resistin, the most recently discovered of the major adipocyte-derived hormone, was named so because it induced insulin resistance. Resistin signaling through the TLR4 receptors is involved in inflammatory responses, atherosclerosis, and acute lung injury. In humans, genetic and clinical data support a role for resistin in dysfunctional metabolism and related pathologies. As in mouse models, serum resistin levels are elevated during human obesity. High circulating resistin levels in humans is associated with atherosclerosis, cardiovascular disease, congestive heart failure, inflammatory conditions like SLE, IBS, and rheumatoid arthritis. Whether the relationship between resistin and insulin resistance is merely correlative, and whether interventions to antagonize resistin action will be of value in the treatment of metabolic or cardiovascular disease is still undetermined and is being investigated. Coming to steroid hormones. The ability of adipose tissue to metabolize sex hormones and glucosteroids is well known. Adipose stromal cells are involved in the interconversion of steroids. For example, 17-beta hydroxyl steroid oxidoreductase converts androstenedione and adrenal androgen to testosterone and estrone to estradiol. The local production of sex steroids may be an important determinant of fat distribution. Estrogen stimulates adipogenesis in the breast and subcutaneous tissue, whereas androgens promote central obesity. Now, these are all the other rest of the hormones produced by the adipocytes. The three we have talked in detail. The others are IGF-1, which stimulates proliferation of a variety of cells and mediates many cells and many effects of the growth hormone. TNF-alpha, IL-6, and PI1. These are the pro-inflammatory hormones secreted. Angiotensinogen is a precursor of angiotensin 2. Then free fatty acids, which are oxidized in tissues to produce local energy. ASP, which influences the rate of triacyl glycerol, that is TAG, synthesis in the adipose tissue. VEGF stimulates angiogenesis, and adipsin potential relation between the complement pathways and adipose tissue metabolism. So these are not so common, but the ones that are highlighted in black, they are all the inflammatory cytokines, and these three we have read in detail. The cell types in adipose tissue. Besides adipocytes, the adipose tissue comprises of endothelial cells, blood cells, fibroblasts, pericytes, periadipocytes, macrophages, and several types of immune cells. These non-adipocyte cells types are called the adipose tissue stromal vascular fraction, or SVF. Cells in the SVF produce hormones and cytokines that can act in a paracrine manner on the adjacent adipocytes. In obesity and type 2 diabetes, the TNF-alpha is produced at the AT macrophages and acts on adjacent adipocytes within the adipose tissue to promote insulin resistance. Hence, the presence and dynamic interactions of the SVF cells is important, especially when determining the cellular sources of the adipose tissue-derived paracrine and endocrine hormones. So these are the fat cells, and these are the rest of the other cells. When you centrifuge, fat cells come at the top, the rest remain down, and you can study all the different cells present here. The metabolic dysfunction associated with adipose tissue, which is very important. Adipose tissue expandability and the metabolic health. Here, one point which is very important to know is that the white adipose tissue retains the ability to expand during adult life to accommodate chronic excess calorie intake. Adipose tissue can expand by two ways: by adipocytes accumulating lipid and growing in size, which is called hypertrophy, or they can increase the number, which is called hyperplasia, or increasing in both hyperplasia and hypertrophy. Now, evidence suggests that the capacity of the subcutaneous adipose tissue to expand and the manner of expansion, that is hypertrophy versus hyperplasia, can influence cardiometabolic health. So the presence of enlarged hypertrophic adipocytes, a lack of hyperplasia, and development of adipose tissue inflammation and fibrosis reflects impaired adipose tissue expansion and metabolic derangement. So when the hypertrophy takes place, it can lead to a metabolic derangement, whereas hyperplasia is supposed to be healthy. These observations support the adipose tissue expandability hypothesis, which is lack of hyperplasia resulting in the limited capacity of the adipose tissue to expand and store lipid, causing ectopic fat depositions and lipotoxicity in the non-adipose tissue structures like skeletal muscle and liver. Happens when the cells hypertrophy and do not have hyperplasia. So the fat looks for ectopic areas. And you have sarcopenic obesity, you have non-alcoholic fatty liver disease. The degree of ectopic lipid deposition in the liver and skeletal muscle determines the metabolic syndrome and the development of type 2 diabetes and cardiovascular disease. So here you have a normal, healthy white adipose tissue expansion where it is leading to hyperplasia. The cell numbers are increasing. But here this is hyperplasia. The cells remain the same, but the expansion is more. So they become unhealthy, and this will be metabolically unhealthy thing. Adipose tissue inflammation. Adipose tissue inflammation is considered a major contributor to the metabolic dysfunction associated with obesity. During nutrient excess, the adipose tissue expandability reaches its limit. A strong association exists between adipocyte size and adipocyte depth. So the adipocytes keep, the demise also takes place at the same time. So during the process of clearing the debris, the macrophages acutely produce inflammatory cytokines. In obesity, this cytokine production often fails to resolve, becomes chronic, leads to impaired adipocyte insulin signaling, further inflammation, and a continuing worsening of the adipocyte tissue dysfunction. Now, lastly, coming to the metabolically healthy and versus the metabolically unhealthy obesity. 10 to 30% of individuals with obesity have metabolically healthy obesity with favorable metabolic profiles. These individuals have normal insulin levels, normal fasting blood sugar, low incidence of hypertension, and normal lipid profile. Individuals with metabolically unhealthy obesity and comparable BMI with another individual can be metabolically unhealthy and can develop metabolic syndrome. Now, metabolic health risk is not solely dependent upon the body weight. That is what I want you all to understand. The two patients with same BMI, one can be metabolically unhealthy, the other can be metabolically healthy. How is this? Studies have shown that the location of the adipose tissue rather than the overall obesity may be a stronger predictor of metabolic health risk. Visceral, obesity and subcutaneous abdominal adipose tissue gives higher risk of obesity related disorders, while the lower body fat, that is the gluteal and the femoral, is metabolically protective. So here you have two people who have the same BMI, but here the liver is healthy. Here the liver has a lot of fat depositions. Here the visceral organs have fat cells which are having hyperplasia. Here you have the whole lot of cells which are hypertrophic. That here subcutaneous fat cells are more in number, hyperplasia. Here there are hypertrophic. Here the muscle is having, sarcopenic obesity. Here the muscle is clear. So this person will be having low insulin sensitivity, high ectopic fat, hypertension, and all the signs of metabolic syndrome, whereas this person will be metabolically healthy. So this brings us to the very, very important question of what happens to a woman when she undergoes menopause? What happens to the fat? Why does she become metabolically unhealthy? How does the pear-shaped obesity turn into the apple-shaped obesity? And menopause is a risk factor. Yes, a strong risk factor because of the estrogen withdrawal, androgen excess. What is happening? There is a change in body composition, increased total fat mass, increased visceral abdominal obesity, increased subcutaneous abdominal fat, increased ectopic fat storage, decreased peripheral fat, reduced total and peripheral lean body mass, and all this predisposes to a complete picture of metabolic syndrome. So the same lady with the same BMI suddenly becomes metabolically unhealthy, and the gynecoid and the fat related to the human, the female beauty, I should say, suddenly becomes android in nature once the menopause sets in. So what is the way forward now? A recent review that considers the locations and functions of several depots ranging from facial adipose tissue to cardiovascular adipose tissue, adipocytes in the bone marrow, within and between the muscle beds and joints, and they have still to be studied. Much remains to be discovered about the types and nerves present in the fat tissue, which has not been so much touched upon till now, and how they vary according to the adipose tissue type and location. How these adipose tissue nerves act to regulate metabolic homeostasis is a current focus of fat cell biology. Another developing area of fat cell biology is the effect of exercise on adipocyte function. Though it was once considered a mere energy storage site, adipose tissue is now considered an important endocrine organ and site of inflammatory cell signaling that governs not only survival, but also plays critical role in reproduction and in glucometabolic homeostasis. So to conclude, adipose tissue is the primary storage site for excess energy, but is also recognized as an endocrine organ. Adipocytes are a complex cell type involved in generating a number of signals like cytokines, hormones, and growth factors that affect the neighboring cells and also impact target tissues involved in energy metabolism. Research in this area has focused on leptin and adiponectin, which show beneficial effects on insulin action and lipid metabolism. Obesity is characterized by increase in fat cell number, fat cell size, or a combination of the two. More recently, there is evidence that low-grade inflammation within the adipocyte tissue results in the dysregulation of adipocyte cytokine production, contributing to the metabolic syndrome. In the obese state, the adipose tissue is infiltrated by inflamed macrophages that release TNF-alpha and IL-6, both are inflammatory cytokines, thus linking obesity, inflammation, and insulin resistance. It is important to understand the signaling pathways by which adipokines control metabolism and to try to discover new therapies for diseases related to adipose tissues. So love is beautiful. See that you keep healthy. See that you don't have abdominal obesity. Exercise, eat healthy. And I invite all of you to IMSCON 2024, which is at Prayagraj, 23rd, 24th, 25th, my final, event of the year. And I wish to see all of you there. Thank you so much.
Thank you, ma'am. Thank you so much.
Dr. Anita, ma'am, can you please give us the concluding remarks for this?
Okay.
Yes, ma'am.
Yes.
I'm absolutely
Perfect.
sorry for that.
No,
Ma'am,
ma'am.
that's
No,
fine.
ma'am.
So
Ma'am.
this is hyperandrogenism can occur where there is hair growth where we do not want it to be there. And it can be accompanied either or it may not be accompanied with the virilization. And why it is important to discuss this topic today is because we know that there is a larger population, aging population, which is beyond the menopause. So this number is very large, and we are finding clinical and even biochemical evidence of hyperandrogenism. And why this is worrisome? Because the long-term sequelae of non-tumorous hyperandrogenism in post-menopausal women, they are sometimes the cardiovascular mortality as well as morbidity. And the how to remove this? There is some problem. Okay, the postmenopausal ovary remains hormonally active, and it secretes a significant amount of androgens and fewer estrogens years after menopause.
Recording in progress.
Although the estrogen levels are reduced abruptly after menopause, androgen secretions decline gradually and is maintained until the later stages of life. So androgen secretion in postmenopausal women depends on the luteinizing hormone. Now, in both pre and post-menopausal situation, the androgen secretion may be exacerbated further in presence of insulin resistance and hyperinsulinemia. So this is one of the conditions where we can find, which we can find in the obese post-menopausal women, and so they may have hyperandrogenism. Now, this state of, we have to call it a relative androgen excess. This is biochemically identified with the measurement of total testosterone levels, and where they should not be exceeding the pre-menopause. So the pre-menopause levels are about 40 nanograms, but they should not be exceeding this in the post-menopause. That is the most important thing to learn. So after menopause, such testosterone levels, if they are there in the just like the pre-menopause, then they may lead to the development or the reappearance of hyperandrogenic symptoms. Now, after menopause, what happens is that there is increased gonadotrophin levels, FSH, they increase, and they maintain the ovarian androgen secretion besides the estrogen demise. So estrogen demise is there, but androgens keep increasing. And this imbalance between the two after menopause gets further amplified by a decrease in the SHBG concentration. And there is a subsequent increase in the androgen index. What are the signs and symptoms? Like, signs and symptoms will depend on the mild. If it is mild, there will be only hirsutism, there will be oily skin, there may be appearance of acne, and moderate to severe, she may have more of hirsutism, and she may have signs of virilization, and that is the most severe. So there may be facial or truncal hirsutism, as well as loss of hair on the head. And the FG score, the Ferryman-Galway score, has not been validated. So like what we learn from this score to give numbers to different sites and then add and understand the severity. So that is not applicable in cases of postmenopausal women. So that is very, very important. Most important thing to start with is to have a full menstrual history, knowing the time of menarche, how were the cycles, were they irregular initially, what happened just before the menopause, and such histories to be obtained. The timing of acneiform lesions may also be an important information. Any personal history of headaches or visual disturbance may point to, a pituitary disorder like hyperprolactinemia. History of weight, if she says that I have put on so much weight after menopause, that is extremely important. So a weight history, including timing of weight gain. Was it during the childbirth and she never recovered from that? Or was it throughout she kept gaining? Or was it an abrupt gain in weight? Then in menopausal women, we need to have a list of medications and the supplements You may have patients, sometimes they come that I am having this product from Amway, I'm having this product. So sometimes there is a self-medication also to have, to look beautiful or something like that. Or the peers tell them to have this and that. So family history again is very, very important of endocrine disorders like hirsutism or balding, that may be a family thing. So these history has to be taken into account. Then a physical examination. So the evaluation of extent of excess hair growth, extent of acneiform lesions. Now, hair can grow along the linea alba, as you can see in this picture. And this is seen in about 20% of patients. But it is more concerning when it is present on the upper chest, back, and is associated with male pattern of balding and clitoromegaly. So if she has pictures, then you can view the pictures of the patient before and after the onset of symptoms. Now, because the endocrinopathies can lead to postmenopausal hyperandrogenism, visual field testing for a pituitary tumor, evaluating for stigmata of hypercortisolism, and examining for galactorrhea, they are all indicated. And differential diagnosis, mainly some are non-tumorous or benign causes, others are tumorous causes. So the benign causes are most common is PCOS, obesity, then Cushing syndrome, hyperprolactinemia, and use of drugs like glucocorticoids, androgens, even anti-epileptics. Then the tumorous causes, the tumor can arise from adrenal, so it can be an adrenal adenoma or an adrenal carcinoma. It can be a Sertoli Leydig tumor, it can be a granulosa cell tumor, or it may be a metastatic tumor. So this iatrogenic hyperandrogenism, I need to just talk a little bit about it. So one thing is you have to rule out any medications or supplements she's having. Another thing is that what are the drugs? So there may be anabolic or androgenic steroids. So diazole, she may be consuming earlier for endometriosis, or there may be some androgenic steroids she's taking like testosterone, DHEA, androstenedione. So sometimes these are used by the athletes, sometimes they are included in dietary supplements, and sometimes they are used for low energy and a better sexual performance. So some clinicians are prescribing compound combination of estrogen with testosterone or DHEA for an hypoactive sexual disorder. So hormones are used right and left in the anti-aging clinics, and they can cause the serum testosterone levels to escalate to the male range and leading to rapid onset of acne, virilization, the mood changes, the male pattern of balding, and the hyperlipidemia. But the important thing to remember is that even if we are able to point that this is the cause, and if we ask her to stop that, it may take months together for this testosterone level, which is higher, to return to the normal even after discontinuation. Sometimes exposure to the partner's testosterone gel may lead to milder symptoms of androgen excess. So that means we have to take the history of the partner as well. Anti-epileptics like valproic acid or glucocorticoids, again, they can lead to this hyperandrogenism. So a careful review of all medications, the partner's hormonal therapies, these are the key in detecting the reversible causes of postmenopausal hyperandrogenism. Once you have a patient, there is a clinical history, you have done a physical examination, you have done an endocrine evaluation. Then you place her into mild or moderate, or you place her into severe. So mild to moderate will be where testosterone levels will be less than 5 nanomoles. And if they are more than 5, then that will be severe. And there may be presence of virilizing symptoms. If there is no suspicion of androgen producing tumor, you can just subject her to TVS, and further you can do 17 OHP and possibly 24-hour urinary cortisol. And that will give you a guide that there is no tumor, there may be only abdominal obesity, then that is PCOS, and you have to give anti-androgen medication and metformin. If there is a high 17-OHP, if you do a ACTH stimulation test, you may need a genetic testing, and then you have to keep her under CAH, and that is congenital adrenal hyperplasia. So it is treated differently with glucocorticoids, anti-androgen medications. And if this points to the Cushing syndrome, the tests, then in that case, the surgery might be required for this condition. If she is having a virilizing symptom, if the testosterone levels are more than 5, the 5 is an easy digit to remember, but it is nanomoles. So then we have to exclude any androgen producing tumor. So in that case, not only the ultrasound, but we may be required to do a CT or an MRI for especially investigating the adrenal part. And again, you have to differentiate whether it is ovarian tumor or it is adrenal tumor, and you may have to treat the cause. So ultimately then laboratory testing, what do? We have to check the total testosterone and DHEAS. Just a word about this testing thing, that the assays which we order from the lab, they are radioimmunoassay, and they are actually developed for testing levels in men. And they are not very sensitive for detection of very low levels of testosterone in women. They have suggested that liquid chromatography, tandem mass spectrometry, this is the gold standard for measuring the total testosterone levels. And it has got a good sensitivity, a good specificity. And so if one is having access to this, then you are assured that whatever test reports you are getting, they are good. So hyperandrogenism in postmenopausal women should be interpreted in context that both adrenal as well as ovarian androgens decline with age in women. Just a general guideline to distinguish tumorous from non-tumorous, a repetition that total testosterone level less than 150 nanogram or less than 5 nanomoles is indicative of non-tumorous or a benign cause, especially when the virilization is not present. And DHEAS levels greater than 800 nanograms or more than 2000 nanomoles, with a total testosterone level more than 200 nanogram or more than 6.9 nanomoles. This points towards a tumorous or a tumorous cause of hyperandrogenism. Radiologic evaluation. Now, ovarian tumors can be easily distinguished with maybe TVS or TAS. They are very small, but they can be identified. Very rarely you will require MRI in that. So this is a example of ovarian tumor MRI. So you can see the enlarged ovarian tumor. CT or MRI of adrenals is indicative, not in all, but in those women, hyperandrogenic women who have a high DHEAS and other clinical concerns for the Cushing syndrome. So what are the objectives? One is to reduce those androgen levels. This is for long term to improve her metabolic and cardiovascular concerns. Now there is a debate whether a postmenopausal woman who has hyperandrogenism, is she having a cardiovascular concern or not? There are a lot of studies, but this is still debatable. And in postmenopausal women who have virilization tumors and very high androgen levels, yes, in them the hypertension and dyslipidemia may have been reported, but it remains unclear whether these are the abnormalities that increase her CVD risk and how effectively the tumor removal will affect these. So treatment is frequently used to remove the inciting cause and improve the patient's distress. There may be psychological distress because she doesn't like to go out in that condition. So all kind of distress related to androgenic symptoms that we have to take into account. The treatment strategies obviously will depend on the cause of androgen excess. Tumors generally require surgical resection, but other things which go along, especially in women who are obese, are the lifestyle changes, the weight loss, the insulin sensitizers like metformin. They can improve the testosterone to normal levels, but more commonly bilateral oophorectomy is indicated to the non-responders. The GnRH analogs, now these can be used as a medical castration to treat hyperthecosis or ovarian tumors if the patient is not a surgical candidate or if a tumor is not identified on imaging. So insulin sensitizers can suppress the androgens, and the iatrogenic causes of hyperandrogenism can be discontinuation of the causative agent or the medication, and it may be ameliorated with antiandrogens such as spironolactone, flutamide, even cyproterone acetate may help. So the key messages of hyperandrogenism are, these are the women who present with hirsutism and or virilization. Now changes are often mild. More commonly we see mild changes, and they are attributed to normal aging process. And but the causes can span both. It can be benign or it can be tumorous causes. The symptoms are common. However, a workup is indicated to assess the cause. Whatever is there, we have to have a workup to understand the cause. The development of a rapid, if there is a rapid or true virilizing sign and signal like deepening of voice and clitoral hypertrophy, has to be a quick workup for assessing the malignancy. A focused history is most important in diagnosis, along with physical examination and appropriate laboratory and radiologic evaluation. And this can differentiate the two forms. And in the end, I would like to say it is crucial for us to differentiate between the hormonal changes of normal aging as well as the pathological cause of hyperandrogenism. Thank you very much for giving me a chance to talk on this very important topic.
In the slideshow. Yeah.
Yes, yeah.
Yes, ma'am.
Okay. Yeah, at the outset, I thank the organizers. A special word of thanks to Dr. Shushma Virma, because she went on calling me so many times. The president, Menopause Society, and a chairperson for digital education, and Rita Jain, Abbas Singh, our own president, Pushpa Shetty, vice president Anita, my dear Ragini and Anita. And let me thank for the opportunity given to me. But the previous speakers have done it so well. The job for me is very, very easy. And the topic given to me is understanding of insulin resistance at peri and postmenopausal and its management. Okay, it's not moving. Why it's not moving?
And move to the slideshow, ma'am.
Yeah, it is in slideshow only. It's in full screen, no?
Yes, ma'am. It's full screen. We are viewing it.
But madam, sometimes it moves with the without slideshow, madam.
Yes.
The regular slides.
You can try with the next button. Many times it gets a little stuck.
Go to the slide sorter and start moving, madam.
Yeah.
You go on the slideshow.
With this will go, madam. You can move to the next slide. Yes, madam.
Yeah.
Okay. When the topic is given to me, few questions came to my mind. What is insulin resistant? What causes insulin resistant? What are the symptoms of insulin resistant? Who are all prone for insulin resistant? Is there any anthropometric predictors? What are the methods to diagnose? What is the difference between insulin resistance and pre-diabetic? What a woman can do to prevent or reverse insulin resistance? Just to recapitulate, insulin resistance is a failure of target organ like muscle, fat, liver, adipose, and peripheral tissue display resistance to insulin and take up to glucose for energy metabolism. And insulin actually stimulates glucose uptake in adipose tissue through GLUTA4 expression. And this function regulates insulin resistance. Whenever there is some disturbance in signal transduction, and when there is an altered mechanism and function of the insulin receptors, this results in manifestation of insulin resistance. So just to know about difference between insulin resistance and pre-diabetics, insulin resistance, when the cells in muscle, fat, liver don't respond well to insulin and cannot easily take up glucose. But in pre-diabetic means glucose are higher than normal, but it is not enough to diagnose diabetes and usually occurs when there is already an insulin resistance whose beta cells cannot produce enough of insulin. That is the difference. And as we all know, the insulin resistance forms a part of a syndrome, which is very complex and which has got a cluster of medical conditions like it is a risk factor for developing heart disease, stroke, type 2 diabetes. So when you look at it, peri and post-menopause, two things are very much involved in developing insulin resistance, as Dr. Pushpa Sethi was talking about how the changes happens in fat metabolism. The one is aging. Another one is a peri and postmenopausal shift in central obesity. They become android type of obesity. In addition, it has got a sedentary lifestyle, high fat diet and medication. So this has already been touched upon by Dr. Pushpa, and adipose tissue acts as an endocrine organ. It secretes free fatty acids, proteins, adipokinase, adipokines, and inflammatory mediators like leptin, adiponectin, resistin, TNF alpha, and IL interleukin 6. All this excess adipose tissue leads to chronic inflammation, which is a very important role, which play an important role in insulin resistance. And fat is involved in the energy metabolism and harmonic hemostasis also. So it is act as an endocrine organ. When we look at the protective effect of estrogen in different specific organ and insulin sensitivity, in adipose tissue, it improves insulin sensitivity and reduce oxidative stress. In heart, it prevents insulin resistance and prevent cardiomyopathy. In liver, it modulates gluconeogenesis, hepatic insulin resistance, and regulate hepatic sensitivity in adipocytes. Muscular improves insulin-stimulated absorption. Of course, in vascular endothelium, also it increases nitric acid production, improves vasodilation. So during menopausal transition itself, there is a fat redistribution, and it causes associated unfavorable changes in body weight, increased in central body fat distribution. There was a lot of debate was going on, but the major evidence suggests the weight gain in midlife is due to two things: changes in weight due to chronological aging, changes due to change in composition and distribution due to ovarian age. So on an average, a woman will gain weight 0.6 kg per year, especially during menopausal transition, irrespective of the race or the ethnicity. So everybody will try to improve the weight gain. So usually patients will come and tell, after sterilization, I have put on weight, or after IUCD insertion. And another important thing is the result of physiological changes and lifestyle changes. Everyone is doing remote, screen time is more than the walking time. All this can cause. And weight gain, again, the aging, we have a decreased resting metabolic rate and total energy expenditure. This is not felt by the individuals. On top of it, when they add a decreased physical activity, we put on weight. Okay. So the calorie intake and physical activity should be maintained. Otherwise, the midlife people will put on weight because the decreased metabolic rate. So this is a multifactorial thing which why the midlife people are putting on weight. See that it is a sandwich persons, the midlife people. One time, this teenage person is giving a lot of problem. The other side, the in-laws and the old people are there. After some time, the kids leave the home. There is no enough physical activity. There is a stress from unpleasant symptoms of due to the job or at home, and they need few calories, but they don't realize. And there is loss of sleep. All this will put on to a midlife obesity. So coming to the estrogen and fat distribution, which Dr. Pushpa has already touched upon, during premenopausal period, lipid deposition in gluteofemoral adiposity, which is facilitated by lipoprotein lipase via estrogen action to assure adequate stores for reproduction. This lipoprotein lipase activity in gluteofemoral adipocytes is higher than that of abdominal adipocytes. Okay, so there is a redistribution to the visceral fat and the adipose tissue into the abdominal and subcutaneous fat of the abdomen. And this starts from menopausal transition from 3 to 4 years before menopause. And this increment in abdominal fat parallel to the decrease in serum estradiol over time. So this is a curve which is obvious. So when there is a perimenopause and menopause, there is a decrease in estrogen, fat redistribution, it causes abdominal obesity. There is an increase in visceral fat deposition, which has got higher lipolytic changes. These changes are becoming evident right from menopausal transition. So what is happening in midlife? Estradiol concentration, women shows high degree variability, but as mentioned by Madam, the testosterone levels do not change significantly in this period. It is still the same. Only the estradiol concentration degree varies. So they results in the android shape of the obesity. So during perimenopause, there is more rapid increase in fat mass, redistribution of the fat to the abdomen, transition from gynecoid to android pattern of fat. So what is happening because of this? When there is a decrease in estrogen in menopause leads to loss of subcutaneous fat, increase in abdominal, that is a visceral fat. When there is decrease in estrogen, bioavailability of testosterone increases. This increase free androgen index as well as decreases serum hormone binding globulin, decrease lipoprotein lipase activity, and the low estrogen via cortisol increases abdominal fat. So increased visceral adiposity, alteration in plasma lipid concentration, and FSH also stimulate redistribution and contributes to pro-inflammatory milieu. So this is a pictorial explanation for the central obesity. In menopause, there is an intra-abdominal obesity, increased visceral fat, increased pro-inflammatory cytokines, decreased adiponectin, increased free acid. So that reduces the insulin signaling through GLUTA4 synthesis that causes insulin resistance. On the other hand, there is a increased adipose free fatty acids and circulating lipids cause atherogenic activity also. So the insulin resistant, how it happens? Reduced estrogen causes fat redistribution, that is an abnormal adiposity, that is a visceral fat, VAT, and this is the primary factor for insulin resistance. So when we look at it, the visceral fat triggers the increased inflammation, causes changes in lipid metabolism, changes in the gut microbiota, resulting in insulin resistance. All these things are interrelated, and final state of insulin resistance develops. So as we all know, adiposity acts as an endocrine system. It secretes adipokines, which impairs glucose tolerance. Adiponectin is anti-inflammatory. Resistance directly correlates insulin resistance, and visceral fat will release their metabolic byproducts. And there is a lot of free fatty acids, which is directly entering into the liver and accumulates there. And this is called lipotoxicity, and which is causing the insulin. When there is an increased free fatty acids and the lipid inside cells load is increased, causing insulin resistance. So when there is an abdominal obesity, there is a, as I already mentioned, there is a increased free fatty acids, which minimize the suppression of hepatic glucose production and inhibit hepatic insulin. This blunting of re-esterification again increases excess availability of free fatty acid, which is the culprit for peripheral insulin resistance. So a word about estrogen inflammation. Many inflammatory components such as macrophages, monocytes are activated by estrogen through estrogen receptors. When there is a reduced level of estrogen in postmenopause, it is always associated with increased inflammatory state. They're called inflammaging. And postmenopausal, they have increased lymphocyte, monocyte counts, increased the expression of pro-inflammatory cytokines and senescent inflammatory cells. All this causes significantly has an impact on energy metabolism and general metabolic homeostasis. So as I already mentioned, three common things. Inflammation. The inflammation, that is the VAT cell, that is visceral adiposity, is invaded by the macrophages, which causes inflammation, entire inflammation. That is not only in liver, hypothalamus, CNS, and it all secretes, again, the target cell in local tissues. Free fat, that is adiponectin, is reduced, which inhibits insulin receptor signaling. And in addition, it causes oxidative stress. When there is a RYS activates, it increases again a tumor necrosis factor and interleukin-4. All this is a pro-inflammatory. The second cause is the lipid metabolism. That there is a dysregulation in the lipid, which increases the adipokines that cause again insulin resistance. When the lipid cell is overflow and it spills over into the plasma, it again causes free fatty acid elevation. This results in the molecules on non-adipose tissue like skeletal muscle and liver. This is called a lipotoxicity, which contributes toxicity to the pancreatic beta cells. This is how the lipid metabolism and the insulin resistance is there. Another important interesting case is dysbiotic. There is in obesity, there is always an altered composition of microbiota, and they all produce a metabolic products called lipopolysaccharides. That interferes with the junction of the intestine wall, causes a leaky gut, and releases again an inflammatory cytokines and enter the blood and pancreatic beta cells. Not only that, it enters into the brain also through brain-gut axis, and microglial, in addition, also secretes inflammatory cytokines, and which ultimately cause insulin. This thing, the chronic inflammation, lipid metabolism alteration, microbial contribution causes the insulin resistance. What are all the symptoms? See, they may have an inability to focus, increased hunger, intestinal bloating, sleeplessness, and of course, weight gain. Mostly abdominal obesity, they can have depression, acanthosis, increased blood pressure, increased blood triglyceride levels also. So who are all more prone for insulin resistance? Of course, menopause women, perimenopause women with overweight and obesity, when there is a history of gestational diabetes, history of heart disease or a stroke, polycystic ovarian history, health condition like high blood pressure, abnormal cholesterol levels, sleep problems, especially sleep apnea. Certain medicines like glucocorticoids, antipsychotic drug, and some medicines for HIV also can increase the insulin resistance. So there are some clinical markers to measure. BMI, of course, it measures only the body size, but abdominal circumference, waist hip ratio gives an idea about VAT. Because the same BMI, they may have a different visceral fat. Visceral fat is the one which is a culprit, which causes all the insulin resistance, which is ultimately cause a metabolic syndrome. So how do we diagnose? Hemoglobin A1C can be done. It should be between 5.1 and 6.4, fasting blood glucose, OGCT. While this test doesn't measure insulin, but it provides a valuable feedback on glucose tolerance, and measuring insulin level after overnight fasting predict an effective proxy for insulin resistance. So the fasting level more than 30 indicates great insulin resistance, and it should be lower than 12 milliunits per ml. And as we all know, all this HOMA-IR index is frequently used. That fasting glucose and fasting insulin ratio has got an easy way to predict. It should be less than 4.5. When it is less than that, insulin sensitivity is good. But a lot of other tests are also available: hyperinsulinic, glucosemic clamp, insulin tolerance test, insulin sensitive test. These are all involves lot of blood samples. So they have told them, people, the clinicians are say it's better. OGCT is a mainstay in diagnosis of impaired glucose tolerance, and the diabetes mellitus can be, as well as the insulin sensitivity also we can predict. Clinically, it's easier to do it. Another quick test also they are talking about, which is superior than HOMA, and it is this thing. And with insulin resistance, there is a lot of associated conditions can crop up. As we all know, that heart disease, dementia, hyperlipidemia, hypertension, non-alcoholic disease, liver disease, sleep apnea, cancer, colorectal cancer, breast cancer, endometrial cancer. So many cancer are tied up with the insulin resistance. So it takes minimum 2 years to become type 2 diabetes. So it's better to catch them around this phase so that we can prevent the diabetes. So the insulin resistant will go on to hyperinsulinemia, impaired glucose tolerance, then type 2 diabetes. So how do we prevent? A healthy lifestyle, including regular physical activity, balanced diet, and self-maintenance can help to prevent the onset of insulin itself resistance. And whenever, as a clinician, we are interested in preventing certain things. So apart from taking BMI, if we do a routine exam, we have a waist-hip ratio, we can give them, it gives an opportunity to screen them further and give them an advice. So 3 important things for treatment is weight reduction, exercise, and dietary modification. So traditionally, women were doing automatically some exercise. They draw water from the well. They have to carry water for a long distance. They used to see nowadays, this is the scenario. They all sit in front of computers and of course, socialization, smoke, everything. So the weight reduction not only reduces insulin level, improves clinical status, and the androgen level falls 44%. So the weight loss is the first line of therapeutic option. So the strategy to prevent weight excess, physical activity is important. And to prevent weight gain, to achieve weight loss and prevent loss of muscle mass with increasing age. And we have to protect bone mass also. So we have to walk at least half an hour per day and do some exercise. So yoga and acupuncture and some of the traditional Chinese herbal medicine also helps in weight reduction. See this lady, see dance is a very good. Look at her. With all the deformity happening dancing. So that for everybody actually, menopause, we all do dancing. That is a very good exercise. And the reduction in calories each day is needed to achieve weight loss. No single diet, high protein diet, all that thing, it should be consistently and it should show better weight loss, and which you are used to it. And any weight loss should be a healthy one and that can be used for long time. So certain diet reduces insulin resistance, whole grain, vegetables, fruits, low-fat diet, dairy products, dietary fiber, omega-3, and low glycemic index food rich in calcium and magnesium. So we have to avoid the salt, the saturated fats, and the sugar. So that will reduce this thing. So when we eat the vegetables and fruits, your insulin sensitivity increases, and subsequently the risk of metabolic syndrome, calcium, risk of diabetes and hypertension is reduced. The diet rich in calcium, also magnesium, increases our insulin sensitivity. So even there is a genetic component for insulin resistance, it can be managed with diet and exercise, and that way we can control or prevent the diabetes. I like the slogan by IMS. So we have to be fit at 40 to prevent increased weight gain and redistribution of the fat and insulin resistance. When we are fit at 40, we can be strong at 60, independent at 80. And thank you for patient listening.
And Menopause Society and all the seniors present here and my colleagues. This is my proud privilege to moderate a panel with Dr. Nandita Thakkar on a very, very important topic, that is metabolic syndrome. Nobody in the middle of the age, means the majority of the people, they are suffering from this particular problem, and this is very important to discuss when they are being perimenopausal or postmenopausal. So how to go about it, about the hormone therapy. We are very, am I audible properly?
Yes, yes.
Yes, ma'am.
So,
Very clear.
somebody else's volume is also open, I
Yeah.
think so.
I
So-
request all the panelists to just mute right now so that they can unmute when they are answering. I think there is some problem with
So
the.
I think our expert, Dr. Ragini Agrawal, is also there. She there, and our senior members like Abha
Yes,
Singh
yes, I am
madam.
very much here.
Good evening, ma'am. And Abha Singh madam is also here. So we like to have the experts' comments from them, and the panelists are already just introduced to you all. So what is this metabolic syndrome? Basically, this metabolic syndrome has so many arms, like 20 arms of itself. It includes abdominal adiposity, insulin resistance. It causes for the raised blood glucose level. So the hypertension comes, dyslipidemia, resulting in the increased triglyceride level and decreased good cholesterol. It all leads to inflammation, oxidative stress, and pre-thrombotic state, which is very, very hazardous for all the systems of the body. And these all results in the neurological disorder, type 2 diabetes mellitus, PCOS, the non-alcoholic fatty liver disorders, cancer, stroke, and cardiovascular diseases. So coming to one by one and in a very crisp way, how to diagnose these parts of the this MET syndrome. So how to diagnose dyslipidemia, and can dyslipidemia is correctable or reversible? Can exercise has its role? So I will like to go with one of the senior member, Dr. Preeti. Can you Dr. Preeti is there? Professor Preeti?
Yeah. Dr. Preet, ma'am, you need to unmute yourself. Dr. Preet, ma'am, she was there just maybe.
If she is unable to, then Dr. Geeta can answer this.
I think anybody can take the answers. Dr. Geeta, you're there. Please unmute.
Good evening, madam. Am I audible, madam? This dyslipidemia can be it is correctable with exercise, and it is possible to reverse dyslipidemia. We can do the lipid profile, measuring the serum lipids, and check our HDL levels and LDL cholesterol, total cholesterol, triglycerides, and know about our lipid status. Exercise definitely promote the increasing the good cholesterol HDL levels.
Ma'am, exercise will lead to increase in the skeletal muscle mass. So whenever there is skeletal muscle mass is more, it helps prevent dyslipidemia in two ways. One is that the lean skeletal muscle mass, it will lead to increase in the insulin activity and increase in the uptake of glucose. So that will improve the insulin sensitivity because the lean mass of skeletal muscles will increase. Another way exercise will help is that it will estrogen receptors are present on the skeletal muscles, and when the estrogen acts upon the skeletal muscles, they help in fatty acid oxidation and all. So that way, if you build up more skeletal muscle mass, there is more chances of improving the dyslipidemia. So definitely exercise will help now.
And can it be curable? There are various ways.
Yeah,
for
no,
its cure. Is it reversible?
Hypercholesterolemias. See, if this dyslipidemia is because of the dietary habits, it can be cured. But familial and genetic hypercholesterolemias cannot be cured. There are some patients whom, despite diet, they will need some other kinds of therapies, ma'am. Not all can be cured, ma'am.
Okay, I'll ask a very basic intentional question. Something a patient comes to you and you will say exercise. What sort of advice? Okay, doctor, what can I do? They will ask you, what can I do? Can I walk? Can I swim? So how would you give that preliminary assessment that they can do a particular activity?
Aerobic exercises are good at the perimenopausal age group. That means you need to sweat at the end of the exercise process, and therefore the patients this anaerobic cycle, or you can say the fat accumulation status, will change to a better status. So I would suggest aerobic exercise. It can be dancing, it can be swimming, it can be brisk walking, it can be power yoga, anything, any form of exercise, 30 to 40 minutes per day, maybe 4 to 5 days a week, according to her schedule.
Anybody wishes to add something, some important points, because it is about the postmenopausal women as well for the exercises.
Can I speak for the
Yes,
exercise?
ma'am. Yes, ma'am.
So when we talk about the exercise, we have to divide exercise between the aerobic and the resistant exercise. Specifically in the postmenopausal woman, resistant exercise is must to maintain the lean muscle mass, which one of the panelists has said that with exercise we have to improve the lean muscle mass. And not only this, there's always a dialogue between the bone and muscles, which also has an effect. And with the resistant exercise, the bones are also become better, and there's a better muscles and bone coordination.
Yes, ma'am. And one important thing is that all patients are not having the same strength. Sometimes the aerobic or the weight bearing exercises can damage for some specific, like if the patient is having problem with the back or the knee, so they need to design their exercises with the help of some experts. That
Ma'am,
what
also initial walking can help. A gradual brisk walking can help in this. A activity of 60 minutes daily physical activity is also recommended for better health.
Yeah. So thank you very much, all the panelists and the experts for adding this thing. I had added this apart from the hormonal therapy because no management in menopause is without adding the good modification of the lifestyle. So this is one of the important aspect which should be taken care. And also one more thing is important here, Neha. Can you put some light about the food habits, like what to consume and what to not consume to decrease the metabolic syndrome? It also causes the reversal of the metabolic syndrome, because we are talking about the reversal of the metabolic syndrome and hyperlipidemia. So the type of food is also very important, and also few prescription of medicines.
Ma'am, better to go with fruits and vegetables. Good diet rich in calcium and magnesium. And also
about the lipids, what kind
diet
of
which
lipids?
contains good amount of protein.
Okay, so Vinya madam, can you add which kind of lipid are better?
What do you?
Without absolutely nil with the lipids cannot work.
No. We need
Ma'am,
essential
HDL is
fatty
a better
acids.
lipid.
Yeah.
We need
Monosaturated
essential.
omega-3 fatty acids.
Yes.
This can be added like cod fish oil or cod liver oil, and coconut oil is good, ma'am.
See, most of the metabolic steps, they need some enzymes and coenzymes, and those vitamins, coenzymes are carried in the essential fatty acids in the diet. So you cannot say a fat-free diet to any person.
Yes,
Some
yes. So
minimum
it should
amount
not
of
be
fat should be there.
absolutely fat-free. Some good fat should also be there, though it should be in a
In small
limited
amount, small
amount
amount.
only. It should be in and even the low carbohydrate diet should be there, and protein amount should be good for this thing. So our overall objective is to reduce the damaging cholesterol levels. So going ahead with the lifestyle modification. Now coming to the next thing, you can see a beautiful lady about 50 years of age. This is a lean, thin lady, and still she is having diabetes type 2 with vasomotor symptoms. So one question is there that whether the lean thin patients are less likely to have metabolic syndrome, or they can also be affected in the similar manner.
Yes, madam, they can also be affected.
in the similar manner.
So, Dr. Nidhi, in such situation, can we add on HRT, or we should go with the lifestyle modification and the herbal kind of medications, or because she is
I
diabetic,
like
so
to do
should we?
some more assessment we like to do, ma'am, like history of like LFT, RFT, and vascular thromboembolism risk assessment. And if all that is fine, I will like to put this lady on HRT, ma'am, because of her vasomotor symptoms, which are really bothersome and troublesome. So any bothersome and troublesome symptoms in menopause can be worked up. And there are some new menopausal hormone therapy available, which do not affect the metabolic profile, like benzodoxepin, and there are a lot of trials have been done, like the Roots trial and all, where they have shown that this does not affect the metabolic profile and does improve the vasomotor symptoms and the osteoporosis. So lean and thin individual more likely to get osteoporosis, and vasomotor symptoms can be managed by giving her a combination of benzodiazepine and conjugated ECE, available as Duavi tablets in India.
What about this? This was about the bone mass and the osteoporosis,
Yeah, she's
and
lean.
diabetes.
Yeah, right.
But also,
What about the metabolic syndrome?
Yeah.
What about the
I'm
other
also-
aspects of metabolic syndrome? What about their cholesterols? Are they prone for metabolic syndrome? Not only I'm talking about the diabetes, but the other aspects of metabolic syndrome as well.
Ma'am,
Ma'am, MHT will
ma'am, there are some fewer safer new hormonal therapy has been come, which can be considered after doing the more elaborate risk assessment, ma'am.
Okay.
Lean,
Thank you.
slender person can also have metabolic syndrome.
Yes.
It is
So
the visceral fat which is important rather than the adiposity on the abdomen parietes or in the thighs, or so visceral fat, that is so that a lean person can also be having higher. So metabolic syndrome can be there in lean persons also.
just want to add, Vinaya madam here, that not only the visceral fat, but there are other studies which are suggesting that lean metabolic syndrome, where even the visceral fat is not more, the BMI is not very high, the waist circumference is not very high, still it may be, the studies suggest that metabolic disorders are highly prevalent in lean and trim individuals as well. Abnormal metabolic profiles you can see in the lean patients also, though her waist circumference is not very much elevated and is linked with the higher risk of diabetes and CBD. BMI as low as 21 kilogram per meter square, and unhealthy diet and low physical activity. So though the patient is not having a high BMI, not much of visceral fat, but if the unhealthy diet and low physical activity is there, then it is responsible for high insulin resistance and dyslipidemia in the lean but metabolically altered adolescent. So that's why the Indian Menopause Society also says that the waist circumference globally, which is acceptable for diagnosing the central obesity, it is different from for the Indian people. And the waist circumference of less than 90, more than 90 centimeter in man and 80 centimeter in women should go for the action level 2, and alternative anthropometric markers, not only the waist circumference, but the neck circumference and wrist circumferences also should be taken into the consideration for the lean patients with the metabolic syndrome. So this new paper I have gone through, so wanted to add in this. So what
Jyoti, can I
type of,
comment one thing? Jyoti,
yes
can I
ma'am,
comment one thing?
yes
So
ma'am,
one thing also in the lean patients is that those patients are really very difficult to treat also. They
yes.
are more resistant than the obese patient.
because you
only one
cannot
thing I can
get the reduction of fat and other things for them. That is not the choice with you.
Yeah, basically whatever fat they have, it is a defective fat and it is more of the leptin resistance, which leads to there so many other harms, which
Yes.
we found in these patients, that the difference of the fat is very different from the normal patient, whether they are obese or not obese, but fat of the metabolic syndrome patient is very, very different.
So, Professor Geeta, what you will choose for these kind of patient apart from all these options, different kind of options for the HRT, because she is having vasomotor symptoms.
Where we can give the pills, we can give pills and tablets, creams and gels.
So basically, according to you, even the oral medications or the systemic medications are not contraindicated for these patients because she is having diabetes and not having hypertension or the thromboembolic phenomena. These conditions are not given here. So is it so that we can go with the everybody is agreeing that we can go with the oral systemic as well as the non-systemic or the skin patches or the local vaginal rings, suppositories or implants or sprays?
Yes. Yes.
Yes, ma'am.
Yes, ma'am.
Everybody is agreeing
Yes.
on this.
Yes, ma'am.
Yeah.
Yes, ma'am. Yes, ma'am.
So now coming to this beautiful lady, but she is having a lot of fat. Now again the situations are the same. That was the lean diabetic patient and this is the obese diabetic patient with diabetes mellitus type 2. And my questions will be again the same. HRT yes, HRT no. Now she is not lean. She is having so much of fat, visceral fat, the estrogenic kind of fat also, like the lot of emphasis given by the madam just before this, that they can have two type of fats. So she is having all kind of fats. Now HRT yes, HRT no.
Ma'am, HRT can be given, but I will not give oral drugs. We can give because, madam, absorption and bioavailability and side effects or metabolic side effects are much less with these topical preparations. So these lady can be given transdermal patches or vaginal things, but definitely not oral.
So
Ma'am,
ma'am,
HRT
you
not oral.
were agreeing for the HRT systemic in a lean patient, but you are not agreeing for HRT systemic in obese. Why?
Oral.
Yeah, because okay, continue.
Ma'am, that it impairs there are known derangements, ma'am. They are still, ma'am, this lady is also having risk for venous thromboembolism, which was not there in the, and estrogen, madam, bioavailability and these side effects to lipid profile and risk of venous thromboembolism is much more with oral drugs as compared to transdermal. So I think
Ma'am, HRT in diabetics should be given according to their risk of CVD. If there is low risk of CVD, then we can go for oral preparation, low dose oral preparation. And if there is if there is a risk factor for CVD like obesity, like a risk for VT, then low dose transdermal preparation should be used.
So Neha, your emphasis is on that if there is added risk of the side effects of the estrogen, in that condition, you should prefer for the non-systemic hormonal supplementation. Am I right?
Yes. Yes, ma'am.
I would like to add something.
Yes, ma'am.
Basically, whether it is a estrogen alone HRT or estrogen plus progesterone, that has to be decided in such patients because venous thromboembolism risk is basically more related to the progesterone supplementation if we add in estrogen. So that is the question that whether
So,
HRT.
Neha, madam, for
yes or
adding
no.
this point that people always think that estrogen is related to the venous thromboembolism, though the
So
progesterone is a bigger
is
culprit for the
not
venous
related.
thromboembolism. So please put
So-
some light on the types of the estrogen which are having lower venous thromboembolic phenomena and progesterone which are having lower thromboembolic phenomena.
See, the older drug CE, combined equine estrogen, has a more potential for VTE than 17 beta-2 estradiol. So now currently the preference oral drug is shifted to 17-2 beta estradiol, whereas 20 years back we were writing more of Premarin or whatever you can say.
Conjugated equine estrogen. Yes.
Yeah, sure. And second thing, the dose they have reduced. Therefore, the CEE, the dose, the standard dose was 0.625, which they have now reduced to 0.325. Medicine is also available. So that probably a low dose might be protective for BTE rather than 0.6. And as far as progesterone is concerned, MPA is more, methyl medroxyprogesterone acetate has more problems for BTE as compared to dydrogesterone. So therefore, 10 milligram dydrogesterone with 17 beta estradiol, this has come now currently, would like be the drug of choice with minimum risk of venous thromboembolism. Even micronized progesterone has a less risk compared to MPA or norgestrel. The older progesterones have higher risk of venous thromboembolism, and the newer progesterones, to let me simplify this way, they have lesser risk of venous thromboembolism.
And
That's what.
synthetic progesterone should not be used, ma'am. Natural progesterones are better. Should not use synthetic progesterones because that anti-apoptotic properties are not there with the synthetic ones.
So
we have choices of doses also. 2.5 milligram dose of progesterone has also come. So that is a very low dose now. So we can write it actually. Yeah.
Vinaya madam, if the low dose estrogen and progesterone is not working, the patient is perimenopausal, say. If she is not postmenopausal, she is perimenopausal or early postmenopausal, and the hot flashes are really very, very bothersome. And the low dose estrogen and progesterone combinations are not working here. In that situation,
then you will have to.
SERMs, ma'am. We can add SERMs, ma'am. SERMs can be given. Ma'am, it's an early menopause, so we can add SERMs, ma'am. Selective estrogen modulators. We have a lot of studies about raloxifene and benzodoxifene, ma'am. They can be given for vasomotor symptoms and with an additional benefit of bone mineral density. DM.
Are they very good for? Are they very good for the vasomotor symptom? If we compare the menopausal hormone therapy with the SERMs, in that condition, the menopausal hormone therapy comes as grade A. Grade A.
Ma'am, use the combination, ma'am. That's a nice combination, ma'am. Duave is available. That is basodoxifene with the conjugated ethinyl estradiol. So, madam, a combination of SERM with estrogen, madam. These are called as a combination drug, ma'am. That's
PCSC.
Yeah, it is there.
PCSC.
Yeah, PCSC.
Or we can shift to standard dose HRT if not low dose.
Yeah, these who are having, so my message here is that if the patient is having diabetes type 2, so because of diabetes type 2, we need not to go for the low dose kind of treatment, because nowadays the dictum is not the smallest dose, but for the optimum dose of correction of the symptom is important. And this optimum dose will not only help for the later on her heart health, but at present for the correction of her insulin resistance as well. So earlier it was a thought process that diabetes, obesity, they are the contraindications. Like we have nowadays, we are seeing that inclusion of the HRT or the estrogen therapies, they again sensitize the insulin, they again correct the insulin resistance, and these things which are going, they got to revert. So it is not like that only low dose. We have to be more liberal and according to the symptom. Whatever the symptom is, whatever the requirement is, that should be fulfilled. And if you are very much worried, then you can go for the nowadays patches. Arsuma, can you elaborate little bit about the sprays and sprays, because patches are not very well suited for our environment. But nowadays the sprays are also available for the estrogen sprays. And
yes, ma'am, there are certain nasal sprays also.
Yes.
Which can be easily used.
Even the skin sprays are also
Yes,
there.
ma'am.
The skin sprays at the two separate place, that is the that is standard dosing is there. And for progesterone, if we are very much worried, we can go for the
LNGIUS.
yes,
Intrauterine device.
LNGIUS. Yes,
Yes, ma'am.
definitely. Apart from that part was not covered, so I had asked this. That apart from the say, natural progesterone, we can go for the local progesterone also. So now I am handing over for the overweight women, that is not only metabolic syndrome but also having hypertension. So madam, please, Nandita madam, can you take up this?
Ma'am, we have couple of
So
minutes.
supposing you have a patient who's having metabolic syndrome, hypertension.
Nandita madam?
At all, if yes, you hear me?
Yeah, you can
Yes,
continue
ma'am.
with this case, madam.
Yeah.
Yeah. So is that menopausal, overweight, hypertension, metabolic syndrome. These are the four cues that are there.
Again,
What
the
do we
same
do if the
options.
patient asks for
So the
Would
panelists
consider
can
at all
answer here.
if she-
One more question has been added by Nandita madam, that not only the diabetes but also hypertension is also there. Now what should be your choice of hormone therapy?
creams, I mean vaginal
Non
rings and gels.
non-oral non-oral medications.
non-oral medications will be the option of
Good
So-
option.
Cutaneous or
how long
trans.
we consider
And
So
how long would we consider giving this medication? See, that's also important. Not only discussing what, how long, and when does the patient return to you for an evaluation?
Definitely,
Anybody can
definitely. So,
answer
madam,
that.
please put some light on how long it can be given, how long it can be given, how to taper off, or suddenly, abruptly, it can be closed, or what is the maximum time it can be given.
Yeah,
Okay,
so
Nidhi,
we
you
started
said
with low doses, and gradually the dose can be increased till the response is achieved. So we start with the lower dose and increase the dose till response is achieved, and then we continue on the same dose, provided there are no side effects, like
For-
lipid profile is normal.
For
blood
how
sugar is
long we like, madam, if she has now get rid of the vasomotor symptoms and she is having the positive effect on the bone health and all, etc. But now she has to come back to you for the follow up. So for how long in a one time you will prescribe her for that particular dose in which she has got the symptom relief?
Ma'am, 6 weeks we can give. No.
After 6 weeks, if patient is happy with that, so after 6 weeks, what to be done?
Lipid profile, then blood
Correct.
sugar, ma'am, fasting postprandial, pap smear. Ma'am,
Okay, so
and
if the lipid
LFT.
profile is almost same or it is becoming a little bit better, okay, and patient is comfortable with the medication, and say patient is about 53 years of age, now what to do?
Ma'am, she can continue, ma'am, till 60 she can continue. Ma'am, we just keep monitoring, that's it. Till 60 years,
I think every 6 months, I would like
Every
to see
3 to
her.
6
That's it.
months, or you tell her to revert back whenever she finds any side effects. You
headache.
educate her about
Periodic re-evaluation should be
yeah.
done.
You educate her that she should, if she gets any vaginal bleeding or weight gain or any abnormal symptoms, she has to report back immediately. Otherwise, after 3 to 6 months, she can just keep coming to you, have a general checkup, and then data exists for almost continuous usage for 5 to 7 years. But you have to keep her monitoring.
So I think Ritu, you are talking.
Yes, ma'am.
Yes, ma'am.
So, Ritu or any of the panelists, like you said, that data has suggested for 5 to 7 years. But still, I am asking a very practical question. We cannot fix for 5
Yes.
years or 7 years continuously. Even with monitoring, she is all right. She
Yeah.
is improving on all the parameters. She is all right. And then her symptoms are also less. So, can we fix it for 5 years?
No,
And she
No,
is
no,
all right.
we can give it for up to 60 years.
We can give up to 60 years, but is it mandatory to give this to
No, it's
every
not.
patient?
No,
We try
1
to
year
check
is
that.
more than
That's what my practical question is,
one,
that at
1 year
53
is more than
patient is
enough.
coming to you. Now she is
1 year.
54. She is having almost suppression of all the symptoms and taking the same amount. So would you
try to
like to
taper.
give a tapering of the
Yes.
dose?
Yes.
Yes.
We try to
Yes,
taper
ma'am,
her.
we need to taper the dose. Yes, ma'am.
We
So
need to taper the dose and we can stop if the patient is not having any symptoms.
And we can always instruct her if she again have any symptoms, recurrence of symptoms, we will restart it for her. So by tapering, we should go and stop. Like we can't keep on giving her for continuously 5 years or 7 years.
Thank you for this answer, because we all know that this vasomotor instability that is usually in the perimenopausal and immediate postmenopausal period, because of the estrogen receptor sensitization, the sudden abrupt ups and downs of the estrogen causes this kind of thermoregulatory disturbances. When the estrogen level comes down and becomes steady after some time, then this thermoregulatory system also gets well versed with it, and the vasomotor symptoms, strength of the vasomotor symptoms decreases, so that you can decrease down the dose. And if the patient is again having the same symptoms, then you can go. Otherwise, there is no need for this long of the treatment. So what are the later on problems, like if you have tapered down and even you can stop for 1 year, for 2 years, you can stop after that. Then what are the main problems in the later half of the menopause? The problems of estrogen deficiencies are very, very different. So Dr. Soma, can you elaborate what kind of problems in the later half of the postmenopause, like the late postmenopausal symptoms remains, which need the
Ma'am,
treatment?
patient may again have complaints, vasomotor symptoms. The patient may again complain of vasomotor
There
symptoms.
are only
Late menopause is more characterized.
percentage where I agree.
पेंडिंग वाला मत निकालना, देना और इसको पेशेंट की फाइल में लगा।
Shushma, please mute. So there are only few percentage of patients who have the long-term symptoms of the vasomotor problems. There are 50 to 60, 70% patients, they usually get rid of these symptoms in the later part of the menopause. But there are few more. Neha, can you elaborate what are the problems associated with the late menopause with estrogen deficiency? It is not associated with vasomotor symptom. Only 10%, 15% patients are associated with late menopause and vasomotor symptoms. Rest usually get rid of that.
Late menopause is more of bone health problems, more of dementia.
Ma'am, there can be a problem with the CVD. CVD risk increases.
So is estrogen indicated for the CVD risk?
No. Not after the window of opportunity is lost.
Prevention, for prevention, we cannot give estrogen.
And
but yes, it has a positive effect on it.
For prevention, we have already given in the first part.
Yes.
Yes,
in the initial window of opportunity. I'm asking for the later where the estrogen is indicated.
Ma'am, urogenital symptoms, ma'am.
Very good. Thank you, madam, for this answer. In the second half, the role of MHT is only for the local things. The GSM is the most prominent problem. The bone health and everything is just extra benefit of. This is not an indication. So that was my message I wanted to keep here. So the local type of treatment is important.
In local treatment, ma'am, we should remember if it is like what type of, if she has frequency nocturia, vaginal dryness, and if she has urge incontinence, overactive bladder, then local estrogen will help. But it does not help in stress incontinence. In fact, it even worsens it. Yeah.
Yes. So, Dr. Nandita's connection, if it is stable now, then she can go ahead, or otherwise I will continue.
Ma'am, it's Jaiswal, ma'am.
My connection is not very brilliant because we have an electric problem here. Please continue, Dr. Jyoti. I can.
Okay, thank you, Nandita, ma'am. So, so any one of you who can a little bit elaborate about the known topical therapies.
And most commonly we have used the Premarin cream, ma'am. That is a estrogen cream. And
so which one is better, Premarin or Evolon?
Evolon.
Evolon
is much better. Evolon contains estradiol, so it's much better. With less dose, we get the action, and that is a better bioavailable molecule. as compared to conjugated estrogen, Premarin.
And Evolon is more time tested, and Premarin is the new entrant. 20 years, more than 20 years, we have been using estradiol cream.
What my
Evolon.
expert says.
Expert, let me
Your
hear.
expert is busy with the emergency section, I guess.
Dr. Ragini has left the panel because she
Yeah.
has to attend an emergency LSCS in her hospital.
Singh ma'am is
Dr.
there?
Jyoti, you are an expert. You can tell
Yes.
us.
Okay. Singh ma'am is there, then I will like to have her opinion. Otherwise, though estradiol, as we say that estradiol is more time tested, estradiol is more potent, but it has more side effects as well, and it is not that homely for the postmenopausal women as the Premarin is. That's why we do not want it in the systemic. We do not want it in the local therapy as well. So Premarin should be the first choice for though when we are giving, we should give it for the longer term. When we are giving it locally, it does not affect for the, it does not need for any progesterone to be supported, because it does not need, it does not causes the endometrial thickness. Patients can get it for even up to 1 year of application, and few studies suggest that even up to 3 years they are safe. But still, I will go with Ritu and Vinaya madam, as that the follow-up is very, very important. So every 3-monthly follow-up is important. And we should not give for GSM only for the 2-week, 3-week, 4-week or 6 weeks treatment. For GSM, we should give like 4 to 6 weeks, once daily or twice daily application, and then once daily application, taper it off, and at least they can continue with twice weekly application. Hafte mein 2 baar they can apply, and they can keep that area supple and non-affected. So in that way, a very low dose amount can work. So here I will differ that Evolon, I will like to go with the Premarin. So one is this, and if the patient is having some other problems like the female sexual disorders are also have a problem. So with GSM is one of the component of that. And apart from the local problems, the libido problem is also there. So any suggestion for
Yes.
DHEAS?
DHEAS tablets capsules can be given. Nowadays,
Yes,
we even have
Tibolon.
vaginal
Yes, Tibolon is also good.
good.
Tibolon is
one.
also good. And like this patient, we are not giving here that she is a very late menopausal woman. If she is early menopausal woman, then Tibolon is a very good option for the libido correction, but not in the perimenopausal area. For Tibolon, you need to confirm that patient is postmenopausal. 1 year of amenorrhea, and then only you can give Tibolon. And before giving Tibolon, you have to go properly with the history as for the other MHT. Yes, especially if the history of breast cancers, etc. Even the dense breast, we can give Tibolon, but history of cancer, it cannot be given. DHEAS dose, anybody can
Just a minute, ma'am.
elaborate about the dose?
10 milligram to 25 milligram.
Okay, ma'am. I will ask Dr. Jyoti.
Sushma ma'am, please mute yourself. Ma'am, oral DHEAS could be, as ma'am said, 25 up to 25 mg, and vaginal capsules nowadays are available with 6.57 micrograms.
So yes, so the studies are suggesting that DHEA is very low dose locally if we are giving. They do not increase the androgen levels and the hormonal levels are not affected in the serum, but they work properly at the local area. So this is the new addition, 6.5 milligram small dose, low dose capsules. Otherwise oral, if anybody is taking 10 to 25 milligram is theirs. So coming to the
Dr. Jyoti, sorry to interrupt. Dr. Ambuja ma'am wants to give some inputs regarding the Premarin gel and Evolon cream.
My pleasure. My pleasure.
I
I
asked
was looking
Ankita
somebody
Yes,
senior to give us some insight.
Ankita, please give the access to the ma'am.
Ma'am, the access has already been given, ma'am.
Okay.
Maybe she must be joining. Jyoti ma'am, just to interrupt.
So ma'am, Ambuja ma'am, welcome to you, and you will be the expert for us now, and you can correct us wherever you need to.
Ma'am, how much time we will need, ma'am? Jyoti ma'am?
I think this is
We can
the
wind
last
up with
slide.
this case.
This is the last slide.
Okay, okay, ma'am. Okay. Ambuja ma'am, are you there? I think she's just logged in. I could not see her.
Dr. Jyoti, we
Yes,
just
yes,
go
ma'am.
on with this discussion and then she can chip in once she's in.
Yes,
Yeah.
yes. So again, the conditions we are not changing on, only the patients we are changing here. So this patient is of late post-menopause, about which we have already had some of the discussion that how it should be different while managing late post-menopause and the early post-menopause. This is also the same lady, overweight, metabolic syndrome, hypertension, diabetes, but she is late postmenopause, like say, you can say she is 57, 58 years, 59 years of case. So here
Ma'am, we can
HRT
give it.
What does she
Yes.
has?
Yes,
What
we can.
symptoms she has?
what symptoms she has?
That is the question that we really focus on.
Two
What
types
is
of
the
symptoms.
symptom that we
Two-
require?
Okay, two type of symptoms can be there. One is the elongation of the vasomotor symptom, which we have already discussed that up to 60 she can take. So now if she is having, say she is having vasomotor symptoms even after so many years of menopause, and earlier she has not taken the HRT, but now she came to know that something can be done to her, so she came to you. 58 years, overweight, medicine, hypertension with vasomotor symptoms.
Ma'am, ultra low or continuously low transdermal or transcutaneous estrogen progesterone combination.
So your word continuous is very important, madam, which you have added here, that she should not have cyclical, but the continuous low dose or very ultra low dose we can start off after ruling out all the things where we can, obviously we can give the HRT. Very crisp answer. Thank you for that. And if she is having GSM, that we have already discussed, GSM, for GSM, she
Local
can
creams.
local creams. Is there any foundation of 60 years age or 10 years of menopause in this? For
It is
local?
for systemic HRT. For local,
No, ma'am.
we can weigh the benefits and risk, and then we can go ahead with short-term therapies.
Neha, you have some, you want to say something? You said no. No to what? After 60
Hello?
years, we can give local therapy, or
Yes,
we
we
cannot?
can give.
Yes.
Yes, ma'am.
After
Yes, ma'am, we
60,
can give local
70.
therapy.
So there is consensus that it is for the systemic, not for the local. Rather, the
Yes, ma'am.
local is usually required after 60, 65.
Yes.
We see in our OPDs with the patients with prolapse and all.
Discussion.
Pardon?
We'll wind up the discussion. I think it is
Ah.
time.
Yes, it is all finished, and this is the last slide, and this is the summary that the menopausal hormone therapy can be given to any low risk patient who is having recent menopause, obviously with symptoms, normal weight, normal blood pressure, physically active, 10 years CVD risk is less than 10 years of postmenopause, and CVD risk is less than 5%, low risk of breast cancers, then it is very, very yes for the menopausal hormone therapy if patient is having any type of symptom, menopausal symptoms. For intermediate risk patients like diabetes, smoking, hypertension, obesity, sedentary lifestyle, or any autoimmune disease with hyperlipidemia, metabolic syndrome, in that cases, the high risk or the patient is having high risk of breast cancer or CVD risk of more than 5%. In that case, you take a very, very proper history and see the benefit versus the risk, and for the minimal time required, you can
give.
in case if the patient is having congenital heart disease, CVD, venous thrombosis, stroke, breast cancer, or more than 10 years of menopause and more than 10% of risk of CVD. So this is all about the discussion today. Thanks to Dr. Nandita Thakkar. She has helped for preparation of some slides. And for the metabolic syndrome, MST is not a contraindication. Thank you all dear panelists.